adult congenital heart diseases. Obviously, the prevalence of adult congenital heart diseases is increasing everywhere in the world, particularly in developed countries where cardiac surgery is perfected and is widely spread. So this presentation for today and next Friday will be concentrating on two parts. The first part will be general consideration, including some phenotypic presentations of congenital heart diseases, as well as the various important surgical considerations that brings people with congenital heart disease from pediatric life to adult life. And the second part will be a nutshell expose of the different individual lesions, concentrating on the salient anatomical and physiological features and the important points in the guidelines concerning treatment. In the States, 1.5 million adults are living with congenital heart diseases. About 85% of congenital heart disease now live to adulthood where cardiac surgery is advanced. And astonishingly, about half of these are complex, moderately complex, or greatly complex congenital heart diseases. Now, these guidelines which are presented here are incomplete because last week, we got a new guidelines, or European Society of Cardiology guidelines, extensive guidelines, very well written, and is advisable for everyone interested in the subject to consult these guidelines. There was a guidelines for the American Society of Cardiology and the American Heart Association in 2018. But an important point is that don't consider the guidelines as the sole source of information, because you will not be able to absorb the guidelines without having a strong hold of the pathophysiology and the various manifestations of the disease. And that's why I wrote for you two recent books. This is the first one, the new edition of PARC. This is 25 expose of the congenital heart disease. That's the base. Getzulis is a book which is the largest book and the most comprehensive book about congenital heart disease in adults. So anybody interested in the subject should be acquainted with these two standard textbooks. Obviously, there is no replacement for the guidelines, but you cannot absorb the guidelines without a strong hold of the pathophysiology and other aspects of congenital heart diseases. Now, as you see from this graph, that the surgical outcome in congenital heart disease has been improving over the years, particularly for operations on children between 0 age and 17 age. And if you look into the upper graph here, you will see that of all congenital heart diseases, adults are superseding pediatric congenital heart disease. And for severe congenital heart disease, the lower curve represents the growth of the adult congenital heart disease prevalence over the years. Now, there are certain general phenotypes which should trigger thought about the underlying etiology of congenital heart disease. Now, this is one of them, Down syndrome, the pleasant infant or child with simian crease, as you see in the upper right corner here, slanting eyes, widespread eyes, blue-set ears. It's a trisomy 21, and you know that genetically most of these are due to non-disjunction. A few of them are due to reciprocal translocation, and much fewer is due to mosaicism. If you have Down syndrome, then you think about AV septal defect. The AV septum is a part of the cardiac septum which separates the left ventricle from the right atrium. This is a small piece of tissue which separates it, because normally the mitral valve is displaced cranially in relation to the septal leaflet of the tricuspid valve. And this area which separates the septal leaflet of the posteromedial leaflet of the mitral valve from the septal leaflet of the tricuspid valve is the atrioventricular septum. It's defective in 60% of patients with Down syndrome. And particularly this group of individuals are very prone to pulmonary hypertension. Why? It's not known exactly, but probably because of choanal atresia, which is a common association with Down syndrome. And this is a Turner syndrome. This is a chromosomal disorder. This is different from Noonan syndrome, which is a genetic disorder. Now, this is a chromosomal disorder characterized by normal mentality. With the Noonan syndrome, you might get the mental insufficiency or mental deficiency. These patients have an absent or an abnormal X chromosome and is associated with webbed neck, gonadal agenesis, flat breast, lymphedema in the early stages of life. And the congenital heart disease associated with it is usually bicuspid aortic valve and coarctation. And this is a Holt-Oram syndrome. This is a mutation in the long arm of chromosome 12. And this is the genetic mutation which is illustrated here. And it's characterized by a fingerized or abnormal or a funny thumb with an extra knuckle. And the congenital heart disease associated with it is usually a secundum atrioceptor defect. And this is Noonan syndrome after Jacqueline Noonan, a pediatrician from Pennsylvania. It's characterized by hyperterrorism, low set ear, webbed neck, micrognathia. And as I alluded to, it's not a chromosomal disorder unlike the Turner syndrome, but it is a genetic disorder, again, a mutation of multiple genes on the long arm of chromosome 12. And the congenital heart disease that goes with Noonan syndrome is dysplastic pulmonary stenosis. But most of them, they die because of the associated hypertrophic obstructive cardiomyopathy. So if you diagnose Noonan and you find an evidence of dysplastic pulmonary stenosis by auscultation as well as by echo, then you have to be on the lookout and on the pursuit for hypertrophic cardiomyopathy. They may develop it later in life, and that's usually the outcome of these conditions and the cause of mortality. This is Williams syndrome, a gene deletion in chromosome 7. It's characterized by sunken bridge of nose, by lacy eyes, widespread teeth, ear-to-ear smile, and a small chin, and the congenital heart disease that goes with it is supravalvular aortic stenosis, vitamin D hypersensitivity, which results in hypercalcemia that disappears after the first few years of life, and frequently is associated with mental insufficiency or mental deficiency. Now, there is an important additional congenital anomaly that should be on the lookout frequently patients with conotruncal abnormalities, and I mean by this conditions like, and that's CAPTCH 22. And this is an acronym for a deletion of the short arm of chromosome 22. Is characterized by conotruncal abnormalities, cleft palate, absent thymus gland, and therefore deficiency of T-cell immunity, as well as hypoparathyroidism and hypocalcemia. The importance of this is that in these conditions, Farrow's tetralogy, double outlet, truncus arteriosus, and other conotruncal abnormalities, these patients should be carefully handled because of T-cell deficiency, and they should be taken irradiated blood in case they need blood transfusion during surgery. Now, the recurrence rate of the common adult congenital heart disease, now ACHD, has now replaced in the new guidelines the word GOSH or grown-up congenital heart disease, because now we have an adult people rather than grown-up as the predominant age category for these patients. Now, the recurrence rate for most of these conditions varies between 2 and 4%, except with bicuspid aortic valve, where we have two abnormalities. We have abnormality in the valve, where the recurrence rate is about 8%, and we have the ascending aortopathy or the generalized aortopathy associated with bicuspid aortic valve, and unfortunately, the recurrence rate can go up to 30%. So that should be regarded. It's frequently quoted that bicuspid aortic valve is the commonest congenital heart disease, but this overlooks the frequency of patent foramen ovale, which is encountered in 1/4 of the population, 25%. So it far exceeds bicuspid aortic valve and mitral valve prolapse as genetic disorders. Now, this is the standard chest X-ray, which is frequently used or was used as an indication for the cardiac situs. If you look to the left-hand side, you get the apex of the heart is to the left of the spine, as well as the gas bubble of the stomach. So this used to be described as complete situs inversus. And this, you can get situs solitus with isolated dextrocardia if the gas bubble of the stomach is on the left and apex of the heart is on the right. And you can get levocardia if the gas bubble of the stomach is on the right and the apex of the heart on the left. Now we have at least two modifications of this standard teaching. First of all, the axis of the heart. If you make, I hope the arrow appears. If you draw the heart base on the atrial side and the apex on the ventricular side, then the line connecting the base with the apex is the axis of the heart. If it's pointing to the right, it's dextrocardia. If it's pointing to the left, it's dextrocardia. But the echo people usually try to find the situs by looking at the abdominal aorta and the inferior vena cava, the relation to each other and to the lumbar vertebra. If you have the aorta to the left of the lumbar vertebra and the inferior vena cava to the right of the lumbar vertebra, that is situs solitus. If you have the reverse, that's situs inversus. If you have both the aorta and the inferior vena cava on either side of the lumbar vertebra, this is asplenia, a part of heterotaxia. If you have the aorta centrally in front of the lumbar vertebra and the inferior vena cava is either to the right or to the left, that's left isomerism or polysplenia. And under these circumstances, you have to think of the associated anomalies. Usually the asplenia or right-sided isomerism is associated with single ventricle, and left-sided isomerism or polysplenia is associated with inferior vena cava azygous continuation of the inferior vena cava. This is important because pacing these individuals requires special tactics to approach the venous access in cases of systemic venous abnormalities. Now, this is known to everybody. I just remind the new people coming to see these lectures or to hear these lectures. If you look to lead one, everything is inverted upside down. P wave is inverted. You think either of dextrocardia or a reversion abnormal position of the limb leads by an unworried technician. You differentiate the abnormal displacement, abnormal position of the limb leads from dextrocardia by looking at the precordial leads. And whenever there is dextrocardia, there is no transition zone and there is low voltage in the lateral leads, although there is a normal transition zone in case with misplaced limb leads. So that's simple. Now we go to some of the operations that have changed the scene of congenital heart disease and bringing many of these people who are doomed to die in early infancy and the childhood to adulthood. So we see them in adult life with these operations, and the complications that might arise from these complications is very important to be sought in order to achieve a careful care for such individuals. So this is the Glen's procedure. The classic Glen's procedure was cutting the superior vena cava and attaching it end to side to the right pulmonary artery. And disconnecting the superior vena cava from the right atrium. Now, this operation stopped because it was associated with pulmonary arteriovenous malformations, cyanosis, and paradoxical embolism, and has been replaced by the bidirectional Glen, in which the end of the superior vena cava disconnected from the right atrium is connected end to side with the right pulmonary artery. So it goes to both lung fields and it diminishes the extra flow to the pulmonary circulation, prevented the formation of arteriovenous malformations. Now, this is the first stage of Fontaine operation, which is completed by connecting the inferior vena cava to the undersurface of the pulmonary artery. But the initial operation was connecting the right atrium through an aortic homograft to the right pulmonary artery. Now, we stopped, this operation has been stopped, although few people are still living with this condition. Now, in the present operation is now connecting the inferior vena cava. The first, of course, is the bidirectional Glen, and the second stage is connecting the inferior vena cava through an atrial baffle to the undersurface of the right pulmonary artery, therefore bringing the lower limb circulation, visceral circulation into the pulmonary circulation. Now, this kind of operation is fashioned in order to improve the situation with a physiologically single ventricle, like in conditions with tricuspid atresia, hypoplastic left heart syndrome, double inlet ventricle, and so forth. So all of these conditions, including many cases of heterotaxia, they are subject of Fontaine operation. In the early stages of life, you cannot connect the superior vena cava because the pressure will not be high in the lung and the circulation cannot go with the static pressure of the inferior vena cava. So this stage of Glen's procedure is usually preceded by a modified blaloctausic in order to allow a high systemic pressure to push the blood through the lungs and improve the pulmonary circulation. A few months later, the blaloctausic is taken down and is replaced by the Glen's procedure, and the third stage will be the inferior vena cava connection. Now, because usually the inferior vena cava connection here through this tube generates a high pressure, a high venous pressure with consequent congestive heart failure, hepatomegaly, and because of hepatic congestion. So you get a fenestration of this tube. Now this fenestration is later closed. As a matter of fact, 30% of them close spontaneously, and the rest 70% are closed by intervention. Now, when the venous pressure is high in these conditions and the distended and result in atrial arrhythmia, then the atrium is opened and an extracardiac Fontaine is generated by putting a tube outside the heart and connecting it to the undersurface of the right pulmonary artery. So you have the superior vena cava connected to the upper surface of the right pulmonary artery, and the inferior vena cava is connected to an extracardiac tube. Now, the idea of the extracardiac tube is to relieve the distension of the right atrium, thereby decreasing the occurrence of arrhythmia, at the same time obviating the need for fenestration, which produces a paradoxical embolism and some degree of cyanosis. It's important to realize that the Fontaine circuit functions best if the left ventricle is the functioning ventricle, like in tricuspid atresia. This is completely different from other situations like the hypoplastic left heart syndrome, in which the functioning ventricle is the right ventricle. It's important to realize from the beginning that we don't know anything about how to treat failing the right ventricle. We don't have studies sufficient to inform us about the treatment of right ventricular failure. All the studies are concerning the left ventricular failure and, as a consequence, right-sided heart failure. So in congenital heart disease, most of the heart failure is right-sided heart failure, either because the right ventricle is in the systemic circulation, like in all kinds of transposition, whether the D transposition or L transposition, both of them are characterized by having the right ventricle in the systemic circulation, or because the right ventricle is being subjected to pulmonary hypertension in Eisenmenger syndrome. This kind of heart failure, we don't have any amount of information sufficient to guide us to the treatment or the optimum line of treatment of these patients. So this is no exception. If you have the left ventricle as the functioning ventricle, then the Fontaine circuit functions perfectly. If you have the right ventricle as the functioning ventricle, it functions poorly. So this is because we depend on the diastolic suction effect of the left ventricle on the pulmonary circulation. But at the same time, the survival of patients with Fontaine syndrome for 20 years is about 80%, and the survival free of death Fontaine failure or transplantation after 20 years is 70%. So it's a great temporizing procedure. Although these patients are handicapped, but many of them are in functional class 1 or 2, less frequently in function 3 or 4. There are many complications of the Fontaine operation, so these complications should be sought by any other cardiology or any cardiologist involved in the care of patients with adult congenital heart disease. Anything elevates the pulmonary artery pressure will impair the Fontaine circuit. So if you get an AV valve regurgitation, or you get right or left-sided failure as a result of myocardial dysfunction or valve disease or the like, then under these circumstances, the pressure in the pulmonary circulation rises and the Fontaine circuit fails. At the same time, any stenosis across the circulation in the pulmonary circulation results in poor tolerance to the procedure. Again, atrial arrhythmia, which are common in these conditions, impair the atrial kick, which is needed by the left ventricle or the systemic ventricle. If you lose it, you lose the function of the systemic ventricle, pressure rises, retrograde for transmission of the pressure to the pulmonary circulation will result in failure of the Fontaine circuit. This arrhythmia can be treated by drugs, by catheter ablation, by Mace procedure, or by extra cardiac conversion of the Fontaine procedure, moving an intra-atrial buffle into an extra cardiac tube. Coagulopathy is common not only because of the slow circulation in the pulmonary circulation, but as well because of the liver congestion and the impairment of the natural anticoagulants, including the protein C, protein S, antithrombin 3, and the like. Liver congestion is important and can result over years into liver cirrhosis and even hepatocellular carcinoma. So everyone should be on the lookout by frequent check of the alpha-fetoprotein and ultrasound imaging of the liver, looking for hepatocellular carcinoma, which complicates many of these conditions. The big problem is the protein losing enteropathy, which carries a poor prognosis and is discovered by looking for the fetal albumin. The fetal albumin is the alpha-1 antitrypsin, which pours into the feces and is increased in these patients, as well as the hypoalbuminemia. But looking to alpha-1 treatment is very poor in these conditions, including anticoagulants, octreotide, opening collaterals between the lymphatics of the liver and the small intestine. So even the new guidelines has a disappointing review for this condition, and the only thing to cure this condition actually is heart transplantation. Now, as the congenital heart disease come into adult life, they get exposed to the various classic risk factors, including hypertension, diabetes, and hyperlipidemia, which needs to be treated in these patients. But important points about heart failure is that the results of treatment of right-sided heart failure are at best mixed, and most of our information is concerning left ventricular dysfunction rather than right ventricular dysfunction. And if you try to afterload the systemic ventricle, you increase the right to left shunt, increase cyanosis and the paradoxical embolism. At the same time, cardiac resynchronization and multi-site pacing are still being investigated. The new guidelines doesn't add any new information about this particular point. Remember, with cardiac resynchronization, we are looking for left bundle branch block, and we have an inferior outcome with the non-left bundle branch block. And most of these patients, we have a right bundle branch block, which is a non-inferior and a non-left bundle branch block. And we have a lot of challenges for heart transplantation in these patients. One of them is the presence of antibodies due to multiple prior surgeries and blood transfusion. And the other thing is that referral to heart transplantation is usually late, and so a concomitant multi-organ dysfunction is commonly present, which decreases the outcome of these conditions. Another problem in this group of patients in adult life is the occurrence of arrhythmia, WBW with the Epstein's anomaly, whether Epstein is on the right side as usual or it's on the left side in congenitally corrected transposition. Intra-atrial entrant tachycardia is the commonest atrial tachycardia which is encountered in these patients. It's usually a circus movement around the patches or the scars or the incisions in patients with repair of atrial septal defect, or in patients who are having mustard or Senning operation, that's atrial switch operations in transpositions. Atrial fibrillation is by far less common than intra-atrial entrant tachycardia. If you have atrial fibrillation, think of associated valvular diseases, aortic or mitral, or a single ventricle. Fallus tetralogy, you get a repair of the outer flow tract of the right ventricle. If you make an incision across the pulmonary valve leaks, pulmonary regurg occurs, right ventricular distension occurs and you get the right ventricular tachycardia, also ventricular that they are placed in the right ventricular outflow tract or the interventricular septum. If you mess around with the area of the sinus node, like in repairing a sinus venosus defect or in doing mustard or sending operations, or in patients doing bidirectional glands, these are all operations in the area of the sinus node, which is situated on the epicardial surface of the junction between the right atrium and the superior vena cava. And most important for examination reasons is transposition, congenital corrected transposition. You get AV block 2% per year. Remember, 2% per year L transposition. So when they reach adult life, most of them, they have a pacemaker inserted in. And this brings us to the problems with ICD and pacemaker in patients with adult congenital heart disease. Always think of hemodynamic abnormalities before trying to insert an ICD. This is particularly important in conditions like pulmonary regurg and prepared pharocytology that we just mentioned a while ago. These patients should be having correction of the hemodynamic disturbance before implanting an ICD. Be on the lookout for the correct venous access, because sometimes it's difficult, like in azygos continuation of the inferior vena cava. So sometimes you are forced to make an epicardial placement of the pacemaker. The risk of stroke is increased because putting electrodes on the right side of the heart and there is a right to left shaft results in movement of any embolus or any particulate matter from the right side to the left side of the heart to the systemic circulation. Putting a pacemaker across a sinning or a mustard loop, will result in baffle obstruction. You get baffle obstruction, you get stenosis. Proximal to the stenosis, you get baffle dilatation and baffle leak. All of these needs to be on the lookout and should be corrected. And it's important to try to get biventricular pacing to help ventricular function and AV synchrony in most of these circumstances. Now, the occurrence of sudden death in this group of individuals is important both in the public eye as well as in the professional circle. And the classic teaching is that these are the three common causes of sudden death: hypertrophic cardiomyopathy, blunt trauma to the chest during the vulnerable period of the ventricular recovery, which is called commissio cordis, and anomalous corona. But if you look to what are the causes of sudden death in patients with congenital heart disease, it's all over the place. So we don't have a very peculiar group of or one or two causes for sudden death in these patients. They can be due to Eisenmenger syndrome, corrected transposition, repaired tetralogy of Fallot, with equal incidence, each about 15 to 20%. And as a matter of fact, if you review the recent literature, you will find that in congenital heart disease, the most common cause of sudden death is unexplained. And even if you go to the general the population, it's not the common three. It is still unexplained. Unexplained is the commonest cause of sudden death in these individuals. Now, this is a shameful side of the legendary Paul Wood. He was the master cardiologist of my generation. He is smoking in this, but he is the one who is responsible for the best description of Eisenmenger syndrome. This is father of Ferdinand Eisenmenger, which was the private physician of فرديناند اللي هو اغتيل وقامت الحرب العالمية الأولى عشانه. Now, an Eisenmenger syndrome is defined as pulmonary hypertension associated with shunt that has been reversed or bidirectional in post-tricuspid conditions like VCD, patent ductus arteriosus, or pulmonary window. They occur in 50% of these patients. In the pre-tricuspid positions like atrial septal defect or anomalous pulmonary venous return, partial anomalous pulmonary venous return, they occur only in a minority, 10 to 15% of patients. If the patient is having pulmonary stenosis or subpulmonary stenosis, these are protective against the occurrence of Eisenmenger. And the survival with Eisenmenger, this is important. Survival with Eisenmenger is much better than with idiopathic pulmonary hypertension. So if you look to this Kaplan-Meier graph, you will find that until the age of 40 or about that, the survival of patients with Eisenmenger is similar to normal control. But if Eisenmenger is complicating complex lesions, then they drop off at this stage and they die around 40, 45 years. With simple lesions, many of them reach the age of 60. So remember, in idiopathic pulmonary hypertension, one of the lines of resistant pulmonary hypertension is atrial septostomy. Here, atrial septostomy is already being done because of the presence of a right to left shunt. So that's the reason why these people, they live longer, and because they live longer, they get complications. And this complication should be seriously considered and looked for in patients with Eisenmenger syndrome. The most important is hyperviscosity, which appears as headache, blurring of vision, body aches, muscle aches, and so forth. They are not hand-in-hand correlating with the hematocrit, so there is some discrepancy, although hematocrit elevation is the primary cause for hyperviscosity. The important point is do not phlebotomize these patients except for symptoms. Even if the hematocrit goes up to 70, leave them alone. Leave them alone without doing anything. If you phlebotomize this patient, then the bone marrow will get crazy. It will liberate a lot of red cells that are iron deficiency because the iron stores will be consumed. They are rigid and they get sludged in the circulation, particularly the cerebral circulation, producing a cerebral infarct that might get infected because of paradoxical septal embolism. So iron deficiency should be on the lookout, and be careful that this iron deficiency will be detected by one method only, checking ferritin, not by looking at the blood film or measuring the MCV, because the bone marrow is active in this condition and is producing large red cells, and as a result of that, the MCV will be falsely elevated. I will not tell you anything. So periodic checking of serum ferritin is the only method by which you can detect the associated iron deficiency. You have to correct this iron deficiency to decrease the rigidity of the newly formed red cells. Now, this iron deficiency is corrected by a short course, a week or two of iron. This is in contrast to treating iron deficiency anemia, where you have to replace the stores of iron over 6 months. Bleeding and hemoptysis is common because of ruptured collaterals. Air and thromboemboli is important, particularly if the patients get hospitalized and they get an intravenous infusion. Then particulate matter may cross to the left side of the circulation and embolize. Congestive heart failure we talked about, arrhythmia we talked about, hyperuricemia because of the increased turnover of RNA of the red cells that can produce gout, renal dysfunction, renal calculi, and the increased turn out of hemoglobin will result in calcium bilirubinate gallstones, infections including endocarditis, pneumonia, and cerebral abscess. If the patient with Eisenmenger gets any focal manifestations or even a headache, image the brain, because you will see an abnormality in the brain, a cerebral infarction or a cerebral abscess or encephalitis. Entrapment of the megakaryocytes into the peripheral circulation will result in the liberation of platelet-derived growth factor and the hypertrophy of the periosteal region of the terminal long bones with hypertrophic osteoarthropathy. So gout and hypertrophic osteoarthropathy are causes. Now, therapy for Eisenmenger, give whatever option is going to not improve the oxygenation of this patient, but still option can be given. It has asymptomatic relief for the occurrence of dyspnea, although it doesn't increase the oxygen saturation because of the right to left shunt. The importance of IV filter, I just mentioned it. Avoid pregnancy, extreme high altitudes, extreme exercise, anticoagulation, and tobacco use. Use phlebotomy for symptoms, avoid it. Some people, they recommend doing phlebotomy if the hematocrit exceeds 65% in preparation for large non-cardiac operations. Patients should be adequately hydrated, so whatever you lose during phlebotomy should be replaced by isotonic saline, maybe sodium bicarbonate, to avoid acidosis because of the hypovolemia. Endocarditis is a serious condition, and the major share of the endocarditis recommendations in cardiac patients involves patients with congenital heart disease, and I will come to that shortly. And an important combination is these expensive drugs. These drugs which are used as specific pulmonary vasodilators, including the endothelin receptor antagonists, prostanoids, phosphodiesterase inhibitors in combination. They do not improve survival, but they improve the 6-minute walk test. And down the road, we have heart and heart-lung transplantation with their own limitations and complications. And here we have the prophylaxis of endocarditis in patients with congenital heart disease. If you live in UK, then good luck. And all of this doesn't apply because the National Health Service canceled everything, but this is the American recommendation. A large share of the American recommendation involves patients with congenital heart disease. So these 5 are from the valve guidelines, and these 2 are from the adult congenital heart guidelines. So if you have a prosthetic valve or prosthetic material used for repair, it's an indication. Previous endocarditis is an indication. Unrepaired or palliated cyanotic congenital heart disease is an indication. Completely repaired congenital heart disease by a prosthetic material placed during surgery or by catheter intervention for the first 6 months, or a repaired with a residual defect at the site of the patch or the artificial material is an indication. The first and the third one are also indicated whenever you have a rupture at the time of rupture of membranes during the vaginal delivery because of the frequent occurrence of erectile tear. As you see, these recommendations are only applicable before dental procedures. What about gastrointestinal and respiratory procedures and the skin procedures? The guideline, if you watch it carefully, says if there is an infection, you treat the infection. So it's not free of recommendation. It's if there is an infection in the skin or in the gastrointestinal tract or in the respiratory tract or in this, then you have to cover the infection as a part of the prophylaxis against bacterial endocarditis. So I will move now to the second part of the lecture, which is dealing with adult congenital heart disease, going from the simple to the more complex. I will be covering shunts, including PFO, which is a major concern because, as I said, it constitutes by far the commonest congenital heart anomaly encountered in 1/4 to 1/3 of the adult population. I will discuss atrial septal defect, anomalous pulmonary venous connection, AV septal defect or endocardial cushion defect, ventricular septal defect. And next time I will be covering PGA, obstructive lesions, including coarctation, subaortic membrane, pulmonary stenosis, anomalous coronary, tetralogy of Fallot transposition, and Epstein. Now, the best thing to understand the atrial septal defect is to revise our knowledge about the formation of the atrial septum. Remember, we start with the septum primum from the posterior and apical part of the atrial wall, and as it moves down to cover the ostium primum here, I hope the arrow is clear. It has a hole in the upper part, which is called the ostium secundum. And on the right side of the ostium secundum, the septum secundum develops, which covers it and leaves a foramen ovale in between. If the septum primum is redundant, it creates an atrial septal aneurysm with excursions of 15 millimeters between right and left. And if you have a large ostium secundum, or a deficient septum secundum, you get an atrial septal defect. Now we go into the PFO problem. That's a challenging problem that has not been solved, and I revised the new recommendation that came 2-3 days ago. Obviously, it has not been mentioned in the European guidelines completely. I don't understand why. But this is a big challenge because as I said, it's a common occurrence, and the occurrence of the cryptogenic stroke, that's a stroke without an obvious reason, particularly in young age, under the age of 55, is more common when there is a patent foramen ovale, and is even more common if there is an associated atrial septal aneurysm. but astonishingly, the recurrence is not more common. And that is the reason for confusion of the results of the various studies that I will mention just now. Now, so what we do for patent foramen ovale? First of all, it's a very common encounter. It might be associated with a hypercoagulable state, which increases the occurrence of DVT and paradoxical embolism. It's commonly associated with atrial fibrillation, particularly after closing the patent foramen ovale. And because of that, it's the atrial fibrillation that might be responsible for cerebral embolism rather than the patent foramen ovale. Its relation to migraine with shunting of serotonin and other products has been disqualified by the MIST trial, so it's no longer in vogue. Patients with sleep apnea, they get mild pulmonary hypertension and they get closure of the patent foramen ovale, but before doing that, they might get a paradoxical embolism. Now, the problem is here. We have a variety of studies, at least we have 5 studies, 4 of them are here, and you find the first 3, the closure 1, the respect study, and PC trials, the results did not meet the composite endpoints of transient ischemic attack, stroke, or sudden death. So there is no proof, based on these 3 studies, that closure of the patent foramen ovale is doing any good. Now, there is another study, which is the reduced trial. The results are now available, and it was a surprise. It was not the largest number of cases, because the largest number of cases actually was the respect trial, but it showed that closure of patent foramen ovale resulted in diminution of cryptogenic stroke compared with antiplatelet drugs alone. Another study is the closed trial, reached to the same conclusion. So we have still some controversy about this. So as far as we know at the present time, there is no advantage of PFO closure over medical therapy in cryptogenic stroke in regards to intention to treat hypothesis. There is no data that indicate whether antiplatelet drugs are any better or any worse than warfarin. There is no mention about the new oral anticoagulants because there is no data about their effectiveness. There is no data that PFO closure has an impact on migraine. And in a meta-analysis, it was found that the number needed to treat patients who have closure of the atrial septal defect is large, 67 patients. But if you extrapolate the findings to 20 years, the number needed to treat is just 8 patients. So there is some hope that further studies will support closure of the atrial of the patent foramen ovale. And this is an Italian study which showed that patients with cryptogenic stroke, they get benefit if they are on anticoagulants, and despite that, they get a recurrence of the thromboembolism. Under these circumstances, you close the patent foramen ovale. Many people follow this recommendation, but the American Heart Association, American Stroke Association came very harsh on this recommendation, and they stated that they moved the recommendation of closure from 2B to 3, stating that for patients with cryptogenic stroke and transient ischemic attack and a patent foramen ovale without evidence of DVT, the available evidence does not support a benefit of patent foramen ovale closure. So they require a precipitating factor in addition to the patent foramen ovale in order to justify closing the patent foramen ovale. So the bottom line is probably that factors that enhance the occurrence, the closure of a patent foramen ovale will include the occurrence of thromboembolism, recurrent thromboembolism, if the patent foramen ovale is large, if there is an atrial septal aneurysm, and in the absence of large vessel atherosclerosis. So these are the factors which enhance, but so far there is no firm conclusion about this. If you don't have a firm conclusion, obviously it will not be a subject for the multiple choice question in the exam. Now, what about the other shunts? Atrial septal defect with its types, partial anomalous pulmonary venous connection, atrioventricular septal defects, ventricular septal defects, and patent ductus arteriosus. We will touch on each of these. Now, this is important and very simplistic. What are the chambers that are enlarged in various shunts? If you have a pre-tricuspid valve, then the right-sided chambers are enlarged. So in atrial septal defect, you get enlargement of the right atrium, right ventricle, and pulmonary artery. As a matter of fact, the pulmonary artery is enlarged in any left to right shunt. If you have a post-tricuspid shunt, then the left side of the heart gets enlarged. So you get in VCD, the pulmonary artery, left atrium, and the left ventricle without the aorta. In patent ductus arteriosus, you get the same pulmonary artery, left atrium, left ventricle, plus the aorta. So looking at the chamber which is enlarged can guide you to the site of the shunt. Now we have 5 types of shunts for atrial septal defect. The rarest are the inferior vena cava sinus venosus, as well as the Ragheb syndrome, which is unhooked coronary sinus. The common ones are the ostium secundum, which is right in the middle of the atrial septum, and the superior vena cava ostium sinus venosus, as well as the ostium primum. Now, the ostium secundum is right in the middle of the atrial septum. It's by far the commonest type of an atrial septal defect. You have to, before putting the color, you have to identify the margins of the atrial septum. Every echocardiographer is telling us that you have to have a subcostal view to be perpendicular to the atrial septum, and then you put the color to identify it. Now, what are the important facts about secundum atrial septal defect? 30% have associated malformation, 60% are females. And what the good news is that pregnancy is tolerated very well. These are the enlarged chambers. You know the fixed splitting of the second sound resulting from fixed right ventricular output because of the equivalent compensation of the shunt versus the increased venous return. Everybody knows about that. The direction of the shunt doesn't depend on the right atrial, left atrial compliance, but the right ventricle, left ventricular compliance. If you wanted to keep the right atrium and left atrium, it's pressure rather than compliance. When right-sided heart failure occurs, the jugular venous pressure doesn't elevate, but the patient gets cyanotic because of the increased right to left shunt. That's an important caveat to be noticed. Only 10 to 15% develop pulmonary hypertension, to the extent that we might imagine that these are 2 separate diseases, because now the pulmonary hypertension is a result of increased flow. This is in contrast to the transmission of the high ventricular pressure during systole in ventricular septal defect, and during systole and diastole in conditions of patent ductus arteriosus. The highest pulmonary artery pressure by far occurs in Eisenmenger, complicating patent ductus arteriosus. You might get pulmonary artery pressure 250. Atrial arrhythmias are common. They do not disappear after closing the atrial septum, particularly if closure is done at a later life. Echocardiography is diagnostic. You might need an MRI for localization, particularly in sinus venosus style. Sometimes you get multiple defects in the form of fenestrations. Most of these conditions are done percutaneously now. If you have enlargement of the right side, right atrium, and right ventricle, you close it irrespective of the symptoms. So it's very simple. Secundum, right-sided heart enlargement, close it percutaneously, the large majority, if we are dealing with secundum. Now, these are the different atrial septal defect devices. We have the ambulatory device. We used to have the helix device. Now this is not available. It was used for a small atrial septal defect somewhere between 5 and 18. This is 5 and 32. Now we have the Gore Medical, which has replaced the helix device at the present time. We have obviously other devices. Following closure of an atrial septal defect, you need, as we indicated just a while ago, antibiotic prophylaxis for 6 months after device implantation. Atrial arrhythmia can still remain a common problem. Rare patients develop pulmonary hypertension even after closure of the atrial septal defect. That might substantiate the hypothesis that these are 2 closely associated but separable diseases. Chest pain is important to be on the lookout for the patients after closure, because if you get a chest pain, this means that the device is eroding the posterior wall of the aorta. We know that the atrial septum is attached to the posterior wall of the aorta, so we don't need a rim, a retroaortic rim, to implant the devices because it is supported by the aorta. If you use an implanted device or a larger size device, then it might erode the aorta and produce a fatal condition, hemorrhage, and that's the ominous sign here is the occurrence of chest pain. Should be very, very looked for to avoid this occurrence. Now we come to a more difficult atrial septal defect, which is the sinus venosus atrial septal defect. As I said, it's commonly located between the superior vena cava and the upper part of the septum, much less commonly the inferior vena cava and the septum. And with the superior vena cava sinus venosus, you might get troubles in the diagnosis because in infancy and the childhood, the echo is easy. But in adult life, we can inject a contrast in the right side of the heart, and you don't see a negative shadow here. I hope the arrow is clear. You don't see a negative shadow here because the sinus venosus hole is not seen. If you go to the transesophageal at upper or mid esophagus at 0 degree, you can see the shunt. Some people, they inject milk, and milk is going to opacify the left side of the heart. You can show positive contrast with the left to right shunt. Now, sinus venosus atrial septal defects, the important facts, it constitutes 10% of atrial shunts. It's much more common with the superior than the inferior vena cava. There is common association of anomalous right upper pulmonary veins that it's commonly associated because these abnormalities are located where the sinus node is present. So it's very common to get associated sinus node dysfunction. You might get an ectopic arrhythmia, inferior leads show an inverted P wave. Common association is the crochet QRS complex in atrial septal defect, which is a fragmented QRS complex, almost characteristic of atrial septal defect. It can be missed in adults by just the transthoracic echo, so you need a TE as well as an MRI, and it cannot be closed by a device, so surgical closure is the only available line of treatment. Again, if the right side of the heart is enlarged, it means that the shunt is significant. You don't wait for symptoms, you don't need to make calculations. You make calculation for the QPQS if you are not sure of the degree of enlargement of the right side of the heart. Now, because the sinus venosus is associated with the right side, anomalous upper right pulmonary veins, this can be baffled very easily by a baffle that connects the right upper pulmonary veins through the right atrium into the sinus venosus defect to direct the venous blood coming from the lungs into the left side of the heart. The problem with this, what looks to be a simple operation, is that it can obstruct the venous return from the superior vena cava, and because of messing around in the region of the sinus node, it can produce sinus node dysfunction. So it has been replaced by the Warden procedure. The Warden procedure is a little complicated procedure. You sever the inferior superior vena cava here, then you take the proximal stump of the superior vena cava that it's attaching right superior pulmonary vein, baffle them through the sinus venosus to the left atrium, and the distal part of the superior vena cava is attached directly to the right atrium. The idea is to obviate the need for messing around with the area of the sinus node or obstructing the superior vena cava. Despite that, follow-up of patients with repaired sinus venosus atrial septal defect, you have to be looking for evidence of sinus superior vena cava obstruction, thick sinus syndrome, atrial arrhythmia, and obviously residual defects. Now, the anomalous pulmonary venous return connections is shown on this slide from the right side or the left side. The right upper pulmonary veins can be connected to the superior vena cava or to the junction between the superior vena cava and the right atrium, or it might go to the right atrium itself. It might go as well the right inferior pulmonary veins to the inferior vena cava in the scimitar syndrome. And on the left side, the left superior vena cava is now called the vertical vein. This is a remnant. If it gets fibrous tissue, it's the vein of Marshall. So you get a left upper pulmonary vein draining into the vertical vein, called the vertical vein because of its vertical location. It drains downstairs here to the coronary sinus, and it drains upstairs here to the innominate vein. So if you have a large coronary sinus It can be a left superior vena cava, which is a benign condition, or it can be a left superior vena cava associated with anomalous pulmonary venous return, or it can be the rare form of atrial septal defect, which is unroofed coronary sinus. How to differentiate? A left superior vena cava alone will not produce enlargement of the right-sided chambers. The other two conditions, unroofed coronary sinus or anomalous pulmonary venous return to the vertical vein, is associated with enlargement of the right ventricle and the right atrium. There are a couple of X-ray changes that are characteristics for this different situation. One of them is the snowman sign, the other is the scimitar sign. The snowman sign here, the head of the snowman, is formed on the left side here by the vertical vein, on the right side by the superior vena cava, and the body of the snowman on the right side by the right atrium, on the left side by the left ventricle. And in the Turkish sword or the scimitar sign, this is the right inferior pulmonary vein draining into the inferior vena cava, and it is commonly associated with hypoplasia of the right lung, and this abnormal right lung is supplied by arterial blood supply from the descending aorta. It's liable to bronchiectasis and other more forms of infection. Now, this is an MRI which shows clearly the picture of the vertical veins, innominate veins, superior vena cava, and the anomalous pulmonary venous return from the left side to the vertical vein, which is the remnant of the superior vena cava. And this is the scimitar syndrome, which is draining into the right lower pulmonary vein into the inferior vena cava. Remember, it's commonly associated with hypoplastic left lung, not with dextrocardia, but with dextroversion. The apex is still on the left side, gas bubble of the stomach on the left side, and the location of the infradiaphragmatic large vessels, as we indicated before, is in the correct side. Now, the important pearls about the anomalous pulmonary venous return, you should have a high index of suspicion if the right atrium and the right ventricle are enlarged out of proportion to other clinical findings. So if you have a small ASD, but the right ventricle and the right atrium are enlarged, think about associated anomalous pulmonary, partial anomalous pulmonary venous return. They are very easy to treat surgically if there is an associated sinus venosus. If there is no associated right sinus venosus, they are a big challenge. The pulmonary hypertension, because this is a pre-tricuspid shunt, is rare, and it occurs in later life, and they can be easily missed with routine echocardiogram, so they require usually more advanced imaging and care with the diagnosis of this. Now, if you have a defect in the lower part of the atrial septum, that's atrial septal defect, the primary atrial septal defect, it can be a part of the AV septal defect. And in AV septal defect, because the septum between the left ventricle and the right atrium disappeared, so these two AV valves will be at the same horizontal level. At the same time, you can get a defect in the atrial septum, that's ostium primum, or you get a defect in the ventricular septum, that's ventricular septal defect, or you can get both, and this is the AV canal. The Rastelli classification is a more sophisticated classification. It talks about the insertion of the chorda tendineum to one or the other side or the crest of the ventricular septum, important for surgery, not for diagnostic reasons. Obviously, you have to have a complete diagnosis by echo or other imaging modalities. Now, if you look into the complete AV canal, you have 5 leaflets: the superior bridging leaflet, the inferior bridging leaflet, right inferior leaflet, right anterosuperior, and then a mural leaflet. Now, if you have a complete AV canal, then there is a ventricular septal defect underneath this common valve, and an atrial septal defect of the ostium primum cranial to this valve. Now, if there is no ventricular septal defect, you are dealing with an ostium primum alone. Now, these two parts of the mitral valve are actually considered the anterior leaflet of the mitral valve. And the cleft valve is not cleft, it's a commissure. It's a commissure between the superior bridging leaflet and the left mural leaflet. It's not It's not, so it needs to be closed. There is significant mitral regurg or mitral regurg associated with symptoms, or if it's associated with left ventricular dysfunction. But it's important to notice that this is not a cleft as commonly described, but it's a commissure actually between these two components of the AV valve. Now, important aspects about AV septal defect. The AV valves are divided into 5 leaves with various chordal attachment. This is very well depicted in the Stilly classification. With complete AV septal defect, 70 to 80% they have Down syndrome. And if they have Down syndrome, they usually get pulmonary hypertension at an early stage of life, because of the hypoventilation associated with Down syndrome, partly because of the choanal atresia and the upper respiratory obstruction associated with this condition. The ECG is very informative. The presence of right bundle branch block with left anterior hemi block, heart block is common. Eisenmenger is expected to occur in these patients. So usually when they in adult life, they are Down and they are Eisenmenger. If you have Down and a simple operation like closing an ostium primum, it's being done. If you have Down and a complicated operation, it needs a multidisciplinary decision, considering the opinion of the family and of the patient and the like. Because under these circumstances, these patients sometimes they have marked mental retardation, comorbidity, including renal agenesis, and they cannot tolerate complex operations. So what do the guidelines say about the atrial septal defect? The class 1 indication, closure of the atrial septal defect, either percutaneously, which is the condition, the majority of secondum atrial septal defect can be done, or surgically for other conditions, the other 5 of atrial septal defect is indicated if the right side of the heart is enlarged, the right atrium, right ventricle, without regard to symptoms. Sinus venosus, ostium primum, and the unroofed coronary sinus, you have to have surgical closure rather than percutaneous closure. Now, surgical closure for a secondum atrial septal defect is reasonable if you have, even without symptoms, and even if there is no right-sided enlargement, if you have concomitant heart surgery that needs to be done. So you close the atrial septal connection at the same time. Also, if you get paradoxical embolism or you get platypnea orthodoxia, standing up will result in desaturation, because as the child grows up, the aorta gets kinked, and if you stand up, the aorta gets straightened. The aorta is connected to the anterior part of the interatrial septum. It pulls the foramen ovale and results in the right to left shunts, and this results in platypnea orthodoxia. If you get that, that's a 2A indication for closure of this. Now, this is an important point. What about patients with pulmonary hypertension? Here we apply the 2/3 rule. If the pulmonary artery pressure is more than two-thirds of the systemic pressure, or if the pulmonary vascular resistance is more than 2/3 of the systemic vascular resistance, do not close the defect. If the pulmonary artery pressure, what I'm saying is deviation from what's written on the slide. If you get more than 2/3 systemic pressure or more than 2/3 of the systemic vascular resistance, don't close it. It's contraindicated. If you get less than half of the systemic pressure or less than third of the systemic resistance, you close it. If you get in between, what's in between? Between half the systemic pressure and 2/3, or between 1/3 of the systemic resistance and 2/3, then either you do the pulmonary vasodilator test with nitric oxide, same as with primary pulmonary hypertension, bringing the pulmonary artery pressure 10 millimeters more and below 40 with the same cardiac output, same indications for a positive vasodilator test. Or you can give a combination of pulmonary vasodilators for several months and then repeat the measurements. Or you occlude the septal defect with a balloon and see if the right ventricle can stand it, maintaining cardiac output or not. So I will repeat it again. because this is the American recommendation, and then I will say to you the new European recommendation, which is simpler. So I repeat this. If you get pulmonary hypertension, then you have three categories. If the pulmonary artery pressure is more than 2/3 of the systemic pressure, or the pulmonary vascular resistance more than 2/3 of the systemic vascular resistance, contraindication. If the pulmonary artery pressure less than half the systemic, or the pulmonary vascular resistance less than 1/3 of the systemic vascular resistance, you close it. If you get in between, you do one of two things: acute vasodilator test, chronic vasodilator treatment, or balloon occlusion of the defect. Now, the new guidelines that came 2 days ago said that measure the pulmonary vascular resistance in Woods unit. If it's less than 3, close it. If it's more than 5, avoid, contraindicated. If between 3 and 5, do the 3 things which I just mentioned. So this is important, because this is the how to tackle patients who are presenting with pulmonary hypertension. Remember, these constitute a big share of our congenital cardiac defects associated with an initial left right shunt. Whether we are dealing with AST, VSD, PDA, anomalous pulmonary venous return, aortopulmonary, it's a contraindication for closure of blood. Now, the last topic for today is the ventricular septal defect. As you see in one straight line here, we have 3 types. We have the outlet, we have the membranous, we have the inlet, and away from them, we have the trabecular. Now, sometimes you get enlargement of many of these. So sometimes you get the outlet as a doubly committed, because it's committed to the pulmonary artery and the aorta, or just the infundibular above the crista supraventricularis, or you get an enlargement of the membranous septum by a perimembranous extension. But at the same time, the location doesn't affect the hemodynamic changes, but it's important, obviously, for surgery versus instrument. Now, sometimes the leaflet of the tricuspid تبقى عامله زي الداش بتاع الموتوسيكل او الداش بتاع العربيه. It's called windsock deformity. And sometimes this windsock deformity is formed by not the septal leaflet of the tricuspid valve, but vegetations of bacteria and endocarditis. But I think that should be extremely rare. Important pearls about ventricular septal defect. It's important to realize that these ventricular septal defects can be small. What reaches adult life is either a small ventricular septal defect, or an Eisenmenger septal defect, or a palliated septal defect, or a treated septal defect. So sometimes these patients get complications apart from that, like sudden prolapse of the aortic leaflet into the ventricular septal defect. Even if there is no aortic leakage, it's a +2B recommendation for repair. If you get a free aortic leakage, it becomes a +1 recommendation for repair. You might get a windsock deformity because of the perimembranous ventricular septal defect is being closed by the septal leaflet of the tricuspid valve. And the common unchanged classification for ventricular septal defects classifies them into restricted, with pulmonary to systemic flow less than 1.5, or in infants less than 25% of the aortic diameter. Remember, the aortic diameter is not enlarged in ventricular septal defect. It's enlarged in fetal ductus arteriosus. So in infancy and the childhood, we refer to the size of the aortic mouth, because that's unchanged and is not enlarged, and it forms a good denominator for the size of the ventricular septal defect. Moderately restrictive, QP to QS 1.5 to 2.5, or a diameter between 25 and 75% of the aortic root in diameter, or a large unrestricted above 2.2 QPQS, or a diameter above 3/4 of the mouth of the aorta. A moderate and a large septal defect can result in pulmonary hypertension. Then you apply the 2/3 rule that we are doing. Most of these patients are closed surgically. Very few, particularly the muscular ones, are closed instrumentally. Some of the, and progressively larger number, are being closed of the perimembranous type, particularly if you are sure that they are away from the tricuspid apparatus as well as the aorta. So the guidelines for ventricular septal defect: Class 1, you close ventricular septal defect if the pulmonary to systemic flow exceeds 2. If it exceeds 2, then it's Class 1. If it exceeds 1.5, it's Class 2A. Closure of the ventricular septal defect is also indicated in the very, very, very rare circumstances when you have a history of bacterial endocarditis. This is shown in this nice echo presentations with event cell shock deformity, including the ventricular septal defect. I never still saw this picture in my life. Maybe others have seen them, but it should be rare. And if you have ventricular septal defect with pulmonary hypertension, then you apply the 2/3 rule and you apply the new recommendation, whatever you like, of the European Society of Cardiology that came down. And if you have an irreversible pulmonary hypertension, it's a contraindication. And you can use a device to close the ventricular septal defect if you are away from the tricuspid valve apparatus or the aorta. Otherwise, you need surgery to completely close the ventricular septal defect. So I stop at this stage and get some questions, trying to respond to them as much as I can.
شكرا دكتور محمد.
يا اهلا بيك. اسئله؟
لو حد عنده اسئله يبعتها في الشات دلوقتي.
Next time we will be completing كل الحاجات اللي فاضله: patent ductus arteriosus, coarctation, aortic stenosis, subaortic stenosis, Epstein's anomaly, transposition, corrected transposition, and I will also respond to other questions including double outlet, double inlet ventricle, hypoplastic left heart syndrome, truncus arteriosus, tricuspid atresia, and so forth. But these rare anomalies have not been included in the European guidelines because most of these people die in infancy. So Epstein's, calcitrology, transpositions, total anomalous pulmonary venous return, and coronary anomalies, they are emphasizing these as adult congenital heart disease. So most of the questions will be dealing with that. Questions on double outlet, double inlet ventricle, hypoplastic left heart syndrome usually do not appear on multiple choice questions for the examination. One important point, at least abroad, the new guidelines is not subject to questioning. Usually the guidelines should appear 1 to 2 years before being subjected to selection for examination. But in Egypt, I don't know the situation. So questions.
هو دكتور محمد معلش انا ما سمعتش من الاول، بس حضرتك لخصت الجايد لاينز الجديده بتاعت الادلت كونجنتال في الموضوع بتاع النهارده ولا؟
الجايد لاينز بتاعت الكونجنتال اللي موجوده في ده انكلودد في الحاجات النهارده. So you will not get any deviation from the new guidelines من الكلام اللي بيتقال النهارده او الكلام اللي هيتقال يوم الجمعه الجايه. في جايد لاينز كتيره طلعت: atrial fibrillation, sports medicine, non-ST elevation, myocardial infarction, and congenital heart disease. طبعا اللي احنا اتكلمنا عليه قبل كده مش هنعمل له حاجه، لكن ده including كل الجايد لاينز اللي اتكلموا عنها. الجايد لاين النهارده في حاجات كتيره مش موجوده في الجايد لاينز، لكن يعني موجوده في الجايد لاينز الامريكاني. خد بالك ان الجايد لاينز الامريكاني just 2 years before، يعني prior 2 years، 2018، ما هياش قديمه قوي.
هو في حاجه جديده عن الاي اس دي في الجايد لاينز الجديده؟
البيشنتس with pulmonary hypertension غيرنا ال2/3 رول بان احنا اخترنا او اختاروا رقم 3 وودز يونت، رقم 5 وودز يونت. طبعا انا مش عاوز الخفن الناس، الكلام ده مش هو جديد. ليه؟ لانه احنا كنا زمان بنعمل كده، لكن كان في اعتراض. الاعتراض ده ما تردش عليه في الجايد لاينز. الاعتراض ده انا هقوله ولو اني ما كنتش عاوز اقوله لكن ياسر بغدادي بيجر لنا. ايه هو الاعتراض؟ انك انت لما بتقيس البلمونري فاسكولار ريزيستنس المقام بتاعها هو البلمونري فلو، وبالتالي البلمونري فلو لو زاد البلمونري فاسكولار ريزيستنس تقل. فقبل ما تقفل الاتريال سيبتال ديفكت او الفنتريكولار سيبتال ديفكت انت مزود الفلو في البلمونري سيركوليشن، سو يو ار فورسلي ديكريزنج الفاليو بتاع البلمونري فاسكولار ريزيستنس. بعد ما تقفله تختفي الحكايه دي، وبالتالي يرتفع البلمونري فاسكولار ريزيستنس من غير انك انت ما تبقى قست لا بالطريقه الاولانيه هو ريلايبل ولا بالطريقه الثانيه هو ريلايبل. فعشان كده احنا كنا دايما doubting the value of having an absolute figure as an indication for closure of the defect. وعشان كده الامريكان كولج امريكان هارت شوز انها تعمل ريشيو between pulmonary artery systolic pressure والsystemic systolic pressure او pulmonary vascular resistance وsystemic vascular resistance. لكن اليوروبيان جايد لاينز يبدو انها لقت ان الفرق ما يستاهلش الكونفيوجن ده، فاختارت انها 3 وودز يونت 5 وودز يونت وان بتوين.
طيب حضرتك تنصح بقى ان احنا نستعمل 2/3 رول دايما ولا نستعمل الطريقه الجديده؟
والله انا انكلايند ان انا استحمل التو ثيرد رول. التو ثيرد رول هي ما عليهاش اختلاف، وفي الوقت نفسه تشيل من عندنا الداوتس بتاع الفاليديتي بتاع ميجرنج البلمونري فاسكولار ريزيستنس ان كونديشنز اوف انكريزد فلو.
تمام.
لكن طبعا انا ام نوت ان بوزيشن ان كريتيسايز جايد لاينز مؤلفها 500 واحد.
تمام. طيب هو في سؤال هنا جه يا دكتور محمد، بيقول لحضرتك what is the cutoff point of right atrial أو right ventricular diameters أو pulmonary artery pressure to indicate closure of the ASD؟
دي يعني بتبقى in relation to body mass index، لأن عادة العيانين دول هم سنهم صغير، so usually you look into the tables for body mass index، لكن احنا بنستخدم عادة الفيجرز اللي هي available in the literature. يمكن وفاء العروسي تقدر تقول ايه الارقام اللي بتتقال في increased size. If you are in the borderline او at the edge you calculate.
تمام.
الكالكوليشن ما هياش ايديال ليه؟ يعني الكالكوليشن بتعتبر انك انت الاوت فلو تراكت بتاع الرايت فنتريكل سيركولار، وهو مش سيركولار، هو عباره عن اندنتد سيركل، وبالتالي انك انت الفي تي اي مالتبلايد بالفيلوسيتي مالتبلايد بالاريا مش هيطلع جود فيجر. عشان كده كالكوليتنج كيو بي كيو اس ما هوش فيري اكيوريت. عشان ده السبب. خلينا اعيد الكلام ده تاني. If you have evidence of enlargement then fine. If you don't have evidence of enlargement you calculate. جايز واحد يقول ما تكالكوليت من الاول ما يبقى ادق، ما هوش ادق. ليه؟ لانك انت الرايت فنتريكولار اوت فلو تراكت ما هوش سيركل. الفورمولا مبنيه على انك انت بتضرب الاريا في الفيلوسيتي تايم اندكس. الاريا دي هي مبنيه على اريا بتاع الدايره باي ار سكوير، هي مش دايره، وعشان كده هو كالكوليتنج الكيو بي مش اكيوريت. دي هي السبب ان هو بنستخدم الانلارجمنت. الانلارجمنت قد ايه؟ دي افيلابل في التيبلز، ما فيش فيجر محفوظ بالظبط to be the cut off point usually related to the body mass index. ومع ذلك خلي وفاء تجاوب السؤال ده.
انا ما اعرفش الدكتوره وفاء موجوده ولا لا.
موجوده، كانت بتسلم عليها السؤال في الاول.
طيب دكتوره وفاء حضرتك سامعني؟
الو
دكتوره وفاء سامعني حضرتك؟
انا سامعاك يا ياسر، انت سامعني؟
سامعينك دلوقتي حضرتك. ايوه فندم.
دكتور محمد، تو ماي نوليدج او للدكتور اللي كان بيسال السؤال، حضرتك حطيت في الانديكيشنز اوف سيرجيكال انترفنشن اند كلوجر الكيو اس شنت والبلمونري فاسكولار ريزيستنس بالمونري ارتري. We do not have a cut-off point for right atrial or right ventricular diameter to intervene whether surgical closure or by cath الستان
انت بتقولي الرايت اتريا والرايت فنتريكل.
ما عندناش كات اوف بوينتس، ما فيش رقم معين اقول بعديه انا لازم اقفل.
في تيبلز موجوده سواء للام ار اي او للايكو in relation to body
ايوه
surface area.
ده هيقول انه it is a dilated ventricle or a dilated atrium in relation to the body surface area، لكن ما فيش رقم محدد. اما الاقي مثلا ان الرايت فنتريكل بقى twice its size اقول ان احنا لازم نتدخل في الوقت الحالي. التدخلات زي ما حضرتك اشرت في الجايد لاينز للريليشن اوف ذا شنت للبلمونري فاسكولار ريزيستنس او للبلمونري ارتري بريشر، الرولز 2/3 رولز، لكن ما فيش رقم للرايت اتريوم ولا للرايت فنتريكل.
اوكي. السؤال الثاني يا دكتور ياسر.
السؤال بيقول why bosentan and sildenafil are harmful in pulmonary hypertension secondary to shunts and HFrEF and secondary to COPD.
اولا احنا ما قلناش ان هو سكند، ده بالعكس، ده احنا بنستخدم البروستانويدز، بنستخدم البوزنتان او الاندوثيليال ريسبتور انتاجونست، وبنستخدم البي دي اي 5 انتاجونست. الدراجز دي بنستخدمها they are helpful in Eisenmenger. remember Eisenmenger group 1 pulmonary hypertension, so it's indicated فيهم. احنا بنستخدمهم كرونيكالي عشان ان احنا نشوف هل البلمونري فاسكولار ريزيستنس بتوطى ولا لا. sometimes بنبتدي pulmonary vascular resistance أكثر من 1/3 between 1/3 to 2/3 and then we apply this after 3 or 4 months repeat measurements بنلاقيها قلت عن 1/3 so it becomes operable. فده بيستخدم مش ما بيستخدمش. انك انت بتستخدمها بقى في lung diseases ده another story. ليه؟ اولا الستاديز ورت ان هم not effective. تاني حاجه انك انت لما بتعمل pulmonary vasodilation لان دول specific pulmonary vasodilator في COPD ده معناها انك انت الحتت اللي not aerated عديت عليها دم، وبالتالي desaturation will become more evident. تحصل على عكس النتيجه تماما. Normally when you have a hypoventilated area نتيجه COPD في corresponding vasoconstriction للحته دي. اذا انت جيت في الحته دي هي اللي هي فيها hypoventilation وسعت فيها البلمونري فاسلز بالسبيسيفيك pulmonary vasodilator يبقى النون فنتيليتد area will be transmitting its effect للبلد. So the blood will reach the left side of the heart desaturated and hypercapnic. So it's contraindicated to give specific pulmonary vasodilators in COPD. دي حاجه. الحاجه الثانيه ان in COPD you don't want the patient to have hypotension. So giving any vasodilator, although its effect might not be very marked, will result in diminution of the blood pressure. وبالتالي diminution of the blood pressure ده هو there is a patent foramen ovale, there will be a shunt right to left condition which desaturates the patient. So we don't give specific pulmonary vasodilators except to group 1. جروب 1 منهم الايزنمنجر، وبالتالي الايزنمنجر جيتس هيلب زي ما قلنا في العيانين اللي عندهم بوردر لاين elevation of the pulmonary vascular resistance بنستخدم لهم حاجه من الثلاثه، يا كرونيك سبيسيفيك pulmonary vasodilator، يا اكيوت vasodilator باكتيفيتي تيست، يا بننفليت بالونه في التفكت ونشوف على الرايت فنتريكل مينتيننج الكاردياك اوتبوت ولا لا. Sometimes it's difficult وبنضطر نعمل الثلاثه. Unfortunately انا ما عنديش فكره ان الحاجات دي بتتعمل. غريبه ان احنا كنا بنعملها زمان، بندي سبيسيفيك pulmonary vasodilator وكان اللي بنستخدمه اساسا صوديوم نيتروبروسايد لان ما كانش عندنا نيتريك اوكسايد ولا عندنا obviously بروستاجلاند، لكن كنا بنستخدم صوديوم نيتروبروسايد which is effective.
في سؤال كمان بيقول حضرتك الادفانتج اوف اكسترا كاردياك كوندوي ان فونتانا سيركيليشن.
الادفانتج اوف اكسترا كاردياك كوندوي في فونتانا اوبريشن، اولا الانترا كاردياك كوندوي بتوصل الانفيرو فينا كيفا للاندر سيرفيس اوف ذا بالمونري ارتري. هنا البلد راجع في خلال انبوبه ضيقه عن الرايت فنتركل، وبالتالي البريشر بيرتفع فيها. اما يرتفع فيها يؤدي الى hypertension in the systemic circulation، يحصل liver congestion، liver cirrhosis، hepatocellular carcinoma، ويحصل visceral congestion يؤدي الى protein losing enteropathy. عشان نقلل البريشر في قلب التيوب دي عندنا حيله ان احنا نعمل فيها فينستريشن، نفتحها خرم. ريمبر الحالات دي فيها اتريال سيبتال ديفكت، تيك مثلا ترايكاستيد اتريزي، وبالتالي الخرم ده مش بس فاتح على الرايت اتريوم، ده فاتح على الليفت اتريوم، هيخلي العيان دي ساتوريتد شويه لكن الكاردياك اوتبوت يتحسن. طيب اذا كانت الحكايه دي ما نفعتش وما وطيش البريشر، نعمل ايه؟ بنعمل التيوب من بره الهارت، وبالتالي لما يكون في تيوب من بره الهارت اصبح الرايت اتريوم ما هوش ديستندد، الاريزميا ما هياش ديستندد، الفينس بريشر بيبقى برضه عالي، لكن الرايت اتريال ديستنشن اللي ناتج من الفينستريشن اللي بيؤدي الى اريزميا بيمنع الاوكرنس بتاع الاريزميا. الاريزميا دي معناها ايه؟ معناها راح الاتريال كيك. اذا راحت الاتريال كيك البريشر عالي. الاتريال كيك بتبقى فايدتها ايه؟ يتهيألك ان البريشر بيعلى ديورنج الاتريال كيك، بس هو بيفضي الدم في الفنتركل. لو انت شلت الاتريال كيك المين بريشر في قلب الاتريوم يعلى، المين بريشر في السيستميك سيركوليشن في اللور هاف اوف ذا بودي تعلى، hepatic congestion, protein losing enteropathy. So it's a method to decompress the lower half of the body من الهاي فينس ريتيرن. الجراحين بيعملوا ايه؟ لما بيلاقي ان الانترا كاردياك تيوب بقت كلوزد الفينستريشن لانها بتقفل 30% لوحدها، او لقى ان الفينس بريشر عالي، قام بيفتح الاتريوم ويشيل جزء من الاتريوم عشان يقلل الاتريوم سايز ويقلل الاتريال اريزميا. at the same time تكس التيوب دي بره وبيغيرها، بدل ما هي جزء من الاتريال تيشو بيعملها داكرون او بولي تترا فلورو ايثيلين تيوب، وبالتالي يقلل الاوكرنس اوف اتريال اريزميا. اذا حصل اتريال اريزميا حصل ثرومبوزس وبارادوكسيكال امبوليزم. اذا حصل بارادوكسيكال امبوليزم ده اشكال، واذا حصل امبوليزم في الفونتان سيركوليشن نفسها ده اشكال، لانه هيرفع البلمونري ارتري بريشر والسيركوليشن مش هتقدر تمشي. ريمبر احنا ما عندناش رايت فنتركل، احنا هدف كل الحكايه ان احنا نوبفييت الرول بتاع الرايت فنتركل، سواء لانه ما كانش موجود زي في الترايكاسبيد اتريزيا او كان موجود بس سمول ان سايز زي البلمونري اتريزيا. البلمونري اتريزيا والانتاكت فنتريكولار سيبتم زي ما انتم عارفين بتتقسم الى مونوبارتايت، بايبارتايت، ترايبارتايت. المونوبارتايت فيه انفلو بس، البايبارتايت فيه انفلو واوت فلو، الترايبارتايت فيه انفلو واوت فلو وترابيكولار. كل ما نقل كل ما الرايت فنتركل يبقى الفانكشن بتاعته قليله فبنلغيه. سام تايم ما نلغوش، وده بيؤدي الى 1.5 ventricular repair. ليفت فنتركل زائد نص الرايت فنتركل اللي هو جاي من الانفيرور فينا كده، عملت جلين فخدت السوبيرور بارت اوف ذا بودي للبلمونري سيركوليشن، راح من البلمونري سيركوليشن للليفت سايد اوف ذا هارت، الليفت فنتركل ادي واحد، وخدت الانفيرور فينا كيفا بلاد واديته ثرو ذا رايت فنتركل، فده نص اللي بيجي للرايت فنتركل 1.5 ريبير. غيره.
طيب في سؤال برضك how to diagnose veno-occlusive disease and if specific vasodilators are harmful.
Veno-occlusive disease عبارة عن a rare thrombogenic fibrotic disease including the pulmonary veins أو usually the pulmonary venules and going into the pulmonary vein. Wedge pressure is normal. ليه normal؟ لأنك أنت لو حطيت قسطرة في الحتة اللي مقفول فيها الفين هيقيس فلات لاين، فهتضطر تطلع القسطرة وتدخلها في حتة الفين مش مقفولة، يعني مش كل الفينز مقفولة، فتطلع نورمال لانك انت مفيش اوبستراكشن ديستال ليه. فدي الطريقه اللي احنا بنشخص بيها. طبعا الام ار اي دلوقتي بيسهل العمليه دهيا لانه بيوري هاي ريزوليوشن الثرومبوز بالمونري فينز. ليه الفازو دايليتورز بروبلم؟ لانك انت you will increase بالفازودايليتورز البلاد فلو through the pulmonary circulation. عندك جزء كبير مقفول، الجزء اللي فاضل مفتوح، اذا البريشر هيرتفع فيه. ليه؟ لان البريشر هو الكونتنتس اجينست الكونتينر، فالكونتينر هنا هو اللي هو الريزيدوال هيلثي بالمونري فينز قليله. زودت البالمونري بلاد فلو بالفازودايليتورز، increase the pulmonary wedge pressure, pulmonary edema. Same situation applies for any mitral, left ventricular, aortic, or distal condition obstructing it. So it's contraindicated to give a specific pulmonary vasodilators في pulmonary veno-occlusive disease أو في mitral stenosis أو left ventricular failure أو aortic valve disease. أو we give the specific pulmonary vasodilators only in group 1. ده لما بتتكلم على السبيسيفيك بالمونري فازودايليتور، ده كومبليتلي ديفرنت من الفازودايليتور تيست. الفازودايليتور تيست خرافه. في الواقع ان هي مكتوبه وهتفضل مكتوبه ومش هتتشال حتى لو نزل جايد لاينز كتير، لكن اولويز هيتقال في الجايد لاينز ان دي خرافه. Very few people responded للبالمونري فازودايليتور تيست. وعدد الهدف من البالمونري اكيوت بالمونري فازودايليتور تيست ان هل الكالسيوم انتاجونست افكتيف ولا لا؟ هي ما هياش افكتيف، وعشان كده هو ولو افكتيف اكيوتلي اون لونج تيرم ما هياش افكتيف. وعشان كده الاكيوت بالمونري فازودايليتور تيست حاجه بتتكتب لكن هي ما بتتعملش في السنترز بتاع البالمونري هايبرتنشن، وهي اولموست فاليوليس، وفيري فيري 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 فيو بيبل هيطلعوا بوزيتيف. Look at the criteria of positivity. انك تنزل بالبالمونري ارتري بريشر تحت 40 في 10 ملم او اكثر and you maintain the cardiac output. It's very difficult على فكره انك انت تعملها. We have tried in the past ان احنا do it. It's very difficult. And if this is if it is positive you give calcium antagonist وتفتكر انك انت حليت الامور. After 1 or 2 months calcium antagonist will lose its effect and pulmonary vasodilator test will be negative. So don't depend. افتكر ان في الجوريزمز جديده كتيره للبرايمري بالمونري هايبرتنشن شالت البالمونري فازودايليتور تيست. انا ما بقولش انها غلط، ما بقولش انها اتشالت من الكتب، ما بقولش انها اتشالت من الجايد لاينز، هي موجوده، بس الكلام اللي عليها هو اللي انا بقوله ده.
في سؤال برضك يا دكتور محمد عن calcium channel blockers in secondary pulmonary hypertension. في أي precautions؟
كالسيوم secondary يعني ايه secondary؟ انهي جروب؟ يعني not primary not group 1 no place. No place for calcium antagonists in pulmonary hypertension. pulmonary ما كانش حد غلط. pulmonary hypertension should be treated بالجروب 1 بالسبيسيفيك pulmonary vasodilator، وبقيه الاربعه جروبس التانيين بالتريتمنت of the underlying etiology. If you have left-sided heart failure اللي هي جروب 2 you treat the left-sided heart failure. If you have interstitial lung disease or COPD you treat it. If you have thromboembolic pulmonary hypertension you treat it medically and surgically and medically and by assisted device. If you have miscellaneous conditions without the association of these miscellaneous conditions زي hemolytic anemia مثلا with pulmonary hypertension, so you don't know much. دي 5 groups. ال 5 groups دول هم pulmonary specific vasodilators. They are add-on therapy. They are not replacement therapy. دول مش زي الانتي ابيليبتيك دراجز تشيل واحد وتركب الثاني. دول add-on therapy. وال add-on therapy دول هم indicated for group 1 only. They are very effective. طبعا to a very limited extent يعني ان في idiopathic pulmonary hypertension ما كان يسمى primary pulmonary hypertension. But they are also effective in Eisenmenger. So that's what we are alluding to today. They can be used in Eisenmenger. They are very expensive. Pulmonary calcium antagonists, remember انه الكالسيوم antagonists non-dihydropyridine contraindicated for ventricular dysfunction. And non-dihydropyridine they are not contraindicated but they are not variable. مفيش تريتمنت ليهم الا لو كنت بتعالج systemic hypertension او سبب اخر. البالمونري vasodilator acute pulmonary vasodilator test is a test of the past. Is not a test to be relied upon.
management of Eisenmenger in pregnancy.
Eisenmenger is absolute contraindication to pregnancy. Pregnancy, we divide congenital heart disease into low risk, intermediate risk, and high risk. The high risk هو essentially Eisenmenger cyanotic congenital heart disease أو complex congenital cyanotic heart disease. If the lady gets pregnant ومصممة إنها تكمل pregnancy, she should understand the sequelae بتاعتها. She might get premature termination of pregnancy. She might get low birth weight infants. She might get high fetal mortality. Many of them, they die in the immediate post-operative period because of the disturbed circulation اللي كانت موجودة. لكن اللي بنعمله we admit the patient into a high dependency unit, combined obstetric and cardiologic care. Cardiac anesthesia, not the ordinary anesthesia. If you give vasodilators to this patient, they shunt right to left and they die. So cardiac anesthesia to avoid the peripheral or systemic vasodilatation and to diminish as much as we can ventricular dysfunction, avoid hypovolemia, try to shorten the third stage by vacuum extraction or by low forceps, and most importantly, avoid hypovolemia in the postpartum state. So in a nutshell, it's a contraindication. These patients should get a contraception method before they try to they plan conceive. So the contraception here is usually a progesterone only drug and an intrauterine device. في progesterone coated intrauterine device وبالتالي فيها الاثنين. لكن not estrogen containing intrauterine device because of the hypercoagulability اللي موجوده في العيانين دي اللي اتكلمنا عنها النهارده. So we avoid ان احنا العيانين اللي هم ياخدوا tubal ligation is another method, is done laparoscopically. So these are the two methods. If the patient gets pregnant, then pregnancy should be terminated. If she insists in that completed pregnancy, then high dependency unit, combined obstetric and cardiologic care, cardiac not obstetric anesthesia, careful handling during delivery and in the postpartum period.
في سؤال برضك يا دكتور محمد، الاي سي جي مورفولوجي افتر بيس
Same
ميكر.
applies to complex congenital heart disease. If you get single ventricle, double outlet, tricuspid atresia, truncus arteriosus, total anomalous venous rhythm, same applies. These are high risk pregnancy. طبعا the patient should be counseled على الريسك للفيتس والريسك للمذر and the possibility of having an original disease inherited أو occurrence of congenital heart disease. مش ضروري the same disease but a different disease. اتفضل قول السؤال.
الاي سي جي مورفولوجي افتر بيس ميكر ال تي جي.
ان ايه؟
البيس ميكر الاي سي جي مورفولوجي بعد ما نركب بيس ميكر في ال تي جي اي.
ال تي جي اي لما بنركب فيه اولا ال تي جي اي في عده اشكالات. اللي بيحصل في ال تي جي اي ان الفنتركلز ار انفيرت. ان دي تي جي اي الفيسلز ار انفيرت. ال تي جي اي الفنتركلز ار انفيرت. So the systemic ventricle is the right ventricle which is posterior located, وبالتالي septal activation is without Q wave in the lateral leads and without R wave in the right precordial leads. If you insert a pacemaker في العيانين دول بيبقى معاهم very frequently Einstein's anomaly، وبالتالي مع Einstein's anomaly في Maheim's bundle أو في accessory pathway which can complicate the electrocardiogram. If you pace the right ventricle في العيانين دول the right ventricle أو right sided ventricle اللي هو attached to the right atrium which is the anatomically left ventricle, then you get a reversion site of activation. So you get, as a result of that, white QRS complex in the form of a left bundle branchial block. The Q wave will be disappearing في الحاجات دي. إذا أنت عندك في العيانين دول a bypass tract then delayed يعني افرض انك عندك correct transposition Epstein's anomaly left sided accessory pathway. left sided accessory pathway يمنع حصول الليفت باندل. انت اللي هتبيس الرايت فنتركل يحصل ليفت باندل. الليفت باندل دي تمنع انها حصول، فتحصل على QRS complex narrow without Q wave. Why? Because in the left bundle accessory pathway اللي هي posteriorly directed connected the left atrium بالanatomical right ventricle which is posteriorly located and obviating the transmission delayed بسبب الرايت ventricular pacing. وبعدين انا عاوز اعرف يعني ليه العقد النفسيه دي؟ ما تخليكوا
انا بصراحه يعني انا استغربت السؤال بس ماشي، قلت اقوله برضك للامانه يعني. طيب هو مفيش اسئله ثانيه يا دكتور محمد جات لي؟
تمام. يعني انا try to be simple عشان تقدر تفتكر الحاجات. If you are doing something complicated you'll get into trouble. دي قاعده في كل حاجه including الانترفنشن. اذا انت عملت البروسيدور complicated يبقى you are liable to complication. لو انت الخطوه الاولانيه سليمه وبعدين حصل complication هتسيب الخطوه نمره 2 و3 و4 وتقعد تصلح الكومبليكيشن. Same applies to complicated situation of any sort. سيبكم من الحاجات الكومبليكيتد. Take it simple لان السمبل يخليك تفتكر الحاجه، خلي الموضوع very clear. الحاجات اللي تبان انها complicated كده هو you think about it.
تمام خلاص.
شكرا يا باشوات.
متشكرين جدا.
تسلم يا حبيبي. I hope it was useful.
شكرا دكتور محمد، ربنا يخليك، منتظرين القادمه ان شاء الله.
على الله تكون عجبتك.